Good afternoon. We're going to bring this hearing to order. Thank you. This is Health and Human Services, the Budget Subcommittee number 1. We're pleased to have a number of items for consideration today. We are also pleased to welcome Assemblymember Arambula, who will be presenting a stakeholder proposal on medical interpreters. And we'd like to welcome the Assemblymember to come forward to present, and if there are others in the stakeholder group who will be joining the Assemblymember in that presentation. As we prepare for this issue, I'll just say that we'll have a few members joining us. If we could have the attention of those in the hearing room. We do have other committees and presentations taking place, so we will be moving through the agenda as quickly as we can and joined by other members as they arrive. Member Arambula, we are ready whenever you are. Welcome.
Thank you. California has been a leader of ACA implementation. Since the ACA was implemented, our state has been there to lead to ensure that we have better health outcomes for individuals, improve health care delivery, and reduce unnecessary costs. We have a lot of work, though, to meet all of our needs. One of the key challenges we face is specifically regarding language. Currently, today, there are 40% of all Californians who speak a different language at home. There are over 200 languages spoke within our state, and with Medi-Cal expected to exceed 13.5 million patients, we can expect over 6 million patients will have language needs on Medi-Cal alone. When limited English-speaking individuals attempt to access health care, their language barrier can contribute to inaccurate patient diagnosis, failure to treat diagnosis and symptoms appropriately, and unnecessary costs. I want to share with you one experience from my tenure working on health care on the front lines. 1 in 4 pregnancies ends in miscarriage. My wife and I have been pregnant 4 times, and 1 of our 4 pregnancies ended in miscarriage. I was at work attempting to translate for one of my patients who was also undergoing a miscarriage, and I mistranslated one word. I said, "I'm having a miscarriage," instead of "she was having a miscarriage." My patient started crying. She was crying for me because of the pain of her going through a pregnancy, and she felt sorry for me. And it wasn't until many minutes later when I realized my error in translating. Yo soy un hijo del Valle, nací y crecí en el Valle Central de San Joaquín. Yo puedo hablar en español, pero tengo problema cuando cambian algunas palabras. I have problems when I change certain words, but I make an attempt to speak in the native language of my patients. And I struggled in this moment because I had to bring in an interpreter to help explain to her that she had lost a child as well. In that moment, I realized the pain that I had caused on her as she was starting to acknowledge that she was going through a miscarriage as well. These situations happen all too frequently in our healthcare delivery system, where we are attempting to do the best that we can. But the current model of using telephones is not sufficient. It does not provide the trust that we need. In the community that I represent, we have a large API community of Hmong patients as well. Currently, there are over 20,000 Hmong patients who speak a different language, and we do not have access or an ability to communicate with them. What I am asking, as someone who is on the front lines of healthcare, is that you help us to establish trust, to work with our patients, to speak in a language that we can communicate with them. Currently in English right now, when I give discharge instructions to my patients, on average, only 20% of people understand what I tell them when they leave my doors. 20%. 80% do not. That is English to English translations. I would like to make sure that at a minimum we are doing the same in Spanish and Hmong and other languages as well, so that we can communicate with our patients and express what is going on in their day-to-day life. We know now that federal and state law requires providers and health plans to have language assistance. But in the state of this size and diversity, many challenges and gaps currently exist. For the past 4 years, legislation has been introduced to establish a program for DHS that will support medical interpreter services to limited English proficient Medi-Cal beneficiaries. This proposal makes sense. First, it provides more resources to the providers who need language assistance needs of their patients. Second, it saves the state dollars that might otherwise go towards inappropriate treatments. Third, it brings federal dollars into this state and into our economy. We believe that now is the time to address this issue. We are hoping to encourage this dialogue in this administration to discuss how such a program would be successful in California. I thank you for your time.
Thank you, Assembly Member, for your testimony, and wanted to thank you for what you shared. I think your testimony was clear. I think what you shared was personal, but certainly added great context to how important access to an interpreter is, and someone who also understands medical terminology in addition to the language. Many of us have experienced that we may know words in Spanish or another language, but we may not know the medical terminology to properly assist patients in making good choices. So, again, we thank you for your advocacy and for your testimony, and we welcome hearing from those that you have brought with you.
My name is Sandra Castillo. I'm going to interpret Guillermo Perez.
Yeah.
Mm-hmm.
Mi nombre es Guillermo García Rodríguez. Soy padre de 3 hijos en la ciudad de Oceanside. Gracias por permitirme hablar el día de hoy. Aquí yo tengo unas fotos de mi familia, de mi esposa. Hace ya 5 años mi esposa Elizabeth fue llevada al cuarto de un hospital de emergencias.
My name is Guillermo Garcia Rodriguez. I'm a father of 3 kids from Oceanside. I want to thank you for allowing me to speak in front of you. And I have pictures of my family with my wife, Elizabeth. ¿Quiere enseñar las fotos?
Se las enseño.
Nomás deténgalas enfrente. So he has pictures of his family and the wife also. Ahí nada más póngale. Continúa.
Esta era mi familia cuando estábamos juntos.
This is my family when we were together.
Ella solo tenía 42 años de edad, pero le dio un ataque, un derrame cerebral. Yo la visitaba en el hospital todos los días. No había intérpretes. Mi hijo Guillermo Israel era mi intérprete. Él solo tenía 9 años de edad.
I visit my wife every day at the hospital. She was rushed to the emergency room, and she was only 42 years old. And I was using my son, Guillermo, to interpret, even though he was only 9 years old.
Yo buscaba muchas veces una cara hispana para decirle que me ayudara a interpretar. Mi esposa no podía ayudar. Nadie nos escuchaba. Cuando les decíamos que ella se estaba ahogando porque estaba en vida artificial.
I looked for anybody with a Hispanic face to help them, to ask for help to communicate. My wife was helpless, and nobody was listening to us when we were saying that she was choking with the life support tubes.
Entonces, ella falleció y les tomó a ellos más de un día para encontrar a alguien que me dijera en mi idioma lo que había pasado, porque ella se había ahogado con su vómito y eso le causó una infección en su sangre y luego subió a su cerebro, dándole muerte cerebral.
Then she died, and it took them over a day to find someone to tell me what had happened in my own native language, which is Spanish. Because of her choking, she vomited, and then her blood got infected, and it reached to her brain.
Estoy aquí para decirles que mi esposa Elizabeth murió. Murió sola, sin ayuda, porque no estaba alguien que hablara español. Nosotros necesitamos intérpretes, médicos. Por favor, apoyen esta propuesta de ley. Gracias.
I am here today to tell you that my wife died alone and helpless because there was an interpreter that will speak in Spanish. We need medical interpreters. We need, please, your support. Thank you.
Señor Rodríguez, gracias para hablar hoy. Me lo siento. ¿Para qué pasó a su esposa? Gracias para ayudar a otra gente.
Gracias.
Gracias, Señor. Do you have other testimony that you will be adding for the proposal?
Not at this time.
Thank you. We are not agendized to act on this today, but clearly this is a very, very important matter as lifted up by the two examples that we heard today, and the committee will take this under full consideration as we move forward in discussions in the budget. Thank you again, Señor Rodriguez. Gracias. And thank you for your testimony, Mr. Arambula. Is there any comment from the department, anything on the proposal? If you could respond to the specific questions that were itemized in the agenda, we'd appreciate it, and then we'll take public comment.
Thank you, Chairman. Renee Malo, the Department of Healthcare Services, and I appreciate the opportunity this afternoon to come before you. So there were a couple of questions that you asked us to respond to. So the first question is, does Medi-Cal beneficiaries currently have access to language interpretation by in-person professional interpreters? So yes, our beneficiaries do. So as you know, most of our beneficiaries today are covered through Medi-Cal managed care plans. And through the contracts that we have with the Medi-Cal managed care plans, as well as in conformance with state and federal laws, we do require access to oral interpreters, signers, or bilingual providers and provider staff as key points of contact with Medi-Cal beneficiaries. Interpretation services must be provided in all languages that are spoken by Medi-Cal beneficiaries and are not limited to threshold or concentration standard languages. In addition, medical interpretation services are available to all Medi-Cal beneficiaries at acute care hospitals or at federally qualified health centers. Medi-Cal has 12 threshold languages that we do require our plans and our counties to use for translation purposes, and those languages, the 12 languages, do include English as one of those languages. In terms of our fee-for-service provider network, they are required to meet their legal obligation to provide interpreter services through commercial language line services, contracting directly with interpreters, employing interpreters on staff, and bilingual staff that may be employed in healthcare settings, which are included but not limited to, again, the hospitals, specialty hospitals, nursing homes, and clinics. And under the terms of the contracts with our managed care plans, they are required to provide the comprehensive language access services to limited English proficient beneficiaries. And these services do include 24-hour access to interpreter services, and that can be either in phone or by in person for all limited English proficient members at key points of contact within the contractor's network. There is required to be cultural competency of those staff and training of that staff and the providers and the subcontractors of those managed care plans. And then translation services are necessary for the limited English proficient mandatory Medi-Cal members that reside in a service area whose primary language is not English and who meet a certain threshold given the catchment area of that health plan. Translation services to limited English proficient mandatory Medi-Cal members residing in the managed care plan service area who meet a concentration standard of either 1,000 individuals in a single zip code or 1,500 individuals in 2 contiguous zip code areas. So they do have certain threshold standards that they have to meet in terms of the translation of written materials and providing interpreter or translation services to their Medi-Cal beneficiaries. And then they're also required to make referrals to culturally and linguistically appropriate community service programs that are needed by those beneficiaries. You had also asked a question about if it's possible for us to implement this proposal with a cap funding as it is proposed. And a cap funding is not possible because it does not take into consideration the increased number of beneficiaries and or what their needs may be in terms of language interpretation services. So again, we do have approximately 13.4 million people that are in the Medi-Cal program, and these individuals are served about 80% of our population. They are covered by our Medi-Cal managed care plans throughout the state. And again, it's through those contractual arrangements where they are required to make available these services. In terms of enhanced federal funding and our ability to claim that funding, we do have federal guidance on interpretation services and our ability to claim enhanced federal funding, but it cannot be claimed when that funding is part of a covered benefit or access to that benefit. The way we capitate services to our health plans, we're capitating them for the provision of benefits, and it's not considered an administrative service. And in accordance with the federal requirements, we would have to somehow break that out of the payment that we pay to our managed care plans. So their capitation payment is for the coverage of benefits and then making sure that those services and the language needs of the population that they're covering, that they make available those services. In order to do something different, we would then have to break out that portion of their capitation payment and then set up a different infrastructure for reimbursement for interpreter services. And then we have certain rules that we have to adhere to in terms of time studies and making sure that if such services are provided separate and apart from the benefits, it's more of an administrative service, and we can only provide those services based upon the time that's spent assisting that person getting access to covered Medi-Cal benefits. And so there are like time studies that would have to be undertaken to ensure that we're appropriately what they say is a cost allocation methodology for those individuals and making available that benefit to the covered Medi-Cal beneficiaries. And then the other consideration would be looking at how such services would be dispensed in a timely manner, say in rural areas. You'd also have to take those things into consideration when looking at the proposal that's on the table. And with that, I do welcome any questions that you may have.
Thank you. I do have a few. Could you just break it down for me? I imagine that the department has to keep some data or statistics on the level of success that we have in providing a medical interpreter when needed, whether it's most of the time or 3/4 of the time or a quarter of the time. Is there data capped on these statistics?
I don't have data that specific. I do have data in terms of the population and the languages that they do speak. We do have that information.
I'm more interested. I am interested in the data about the population and the languages. And correct me if I'm wrong. I'm making an assumption that with all the success we've had increasing Medi-Cal enrollment since the Affordable Care Act, that the need for language interpretation has gone up. I'm making that assumption. Is that it?
I mean, our population base has grown. We have seen the highest number of growth in terms of the Hispanic population and those individuals that speak Spanish. That's a population where we have seen the largest growth, but we have seen growth in other areas in our program.
Got it. I'm going to ask for some pointed information. I'm going to ask that this committee be provided with data about that growth in most of the language areas, including Spanish, but not just to have the data, to understand from the framework of what the department needs to, what Medi-Cal needs to be able to provide in order to meet that need. I want to be able to look at this from a statistical standpoint. I'm also interested in understanding better how Medi-Cal keeps track of when an interpreter can or cannot be provided. Is there any data to that effect?
I don't know. That would be something we would have to contact our managed care plans to see if they have that information readily available.
So this committee is requesting to have that type of data.
Okay.
And I understand that there might be averages involved, but I'd like to know what the averages are. On average, how well or not well are we able to provide a medical interpreter? We heard today testimony that is just simply devastating, that there was someone not present during a potentially life-saving emergency, and that even after that emergency, that it took more than 24 hours for someone to be able to speak with the family. And so I want to understand how we work with families when there's an actual emergency, a potentially life-changing emergency. What are the protocols for? I understand that there's shortages and we can't be everywhere, we can't have people everywhere, but what are the protocols when the situation is a life-threatening emergency?
I mean, our expectation would be that the providers would make available those services and or access those services based upon their network and what they're providing to the populations that they are covering. So I can't speak to the specific incident that was described here today, but I can certainly follow up to see what are the standards that the plans are using when they have individuals in need of those services, and then making available those interpreter services. I do know within, say, hospital settings and all, they do have staff on board that can speak different languages, again, based upon the populations that they serve. So recognizing the ethnic makeup or the diversity of the population that we serve, and hearing a story about someone not having access to, say, a Spanish interpreter is a bit surprising, again, but not knowing the particular circumstances, I will certainly follow up to see what I can find out from our health plans in terms of how they deal with situations such as that.
And what is required? I heard you say that our expectation would be that the providers would do certain things. I would like to know what the requirements are, what they are required to do.
Yes, and there are requirements that are spelled out in the managed care plans.
Are there also penalties when they don't meet those expectations?
I don't know what those penalties would be, but I would find out.
So here's our situation. This committee is going to be expected to take action on this and several other proposals within the next 3 weeks. And so what I would like to have is that information provided to this committee and its members within the next week. The information about how often an interpreter can be provided or is not able to be provided, what the requirements and expectations are of those contractors and providers, and if there are consequences for when those needs aren't met. And of course, I want to know what the projections are, meaning, as we've all stated today, that there's been an increase as a result of the Affordable Care Act and enrollment in Medi-Cal, and that much of that enrollment has been with individuals whose first language is not English. Based on that data, I would like to know what the expectations are, the projections are for the availability of medical interpreters. What's the projection of what's needed and what that costs? I would like for that information to be available for the committee members.
Okay.
Thank you.
You're welcome. Thank you.
Any other questions from committee members? Mr. Chu.
Mr. Chair, First of all, I want to thank the Latino Legislative Caucus and AFSCME for bringing this issue forward, and state, as the policy chair of the API Legislative Caucus, our caucus has also prioritized this issue. In fact, we had a meeting with the governor and recently raised this, as I know the Latino Caucus has as well. In addition to the numbers that have already been provided, 16% of our state's population is API, and we know we have literally hundreds of thousands of patients who are trying to get care through language barriers, and we all know how important it is for our members to be able to access care in their language. And so I just want to add the perspective of the diversity of communities that the API Legislative Caucus represents. I do know this is not the final proposal, but I think we look forward to working with all the stakeholders in moving this forward, and I also want to thank our colleague Dr. Ramboulef for his leadership on this as well.
Thank you, Assemblymember Chu. Thank you. We have some public comment. Please come forward, public comment.
Is it possible for me to say something prior to that?
Absolutely, sir. Absolutely.
I wanted to make sure to touch on something I didn't touch on earlier, how imperfect and impersonal telephone interpretation is versus having someone in person. I want you to try and envision what it would be like to have heard his testimony via a telephone. Would you have felt so moved? Would you have answered and reacted differently if you're hearing it over a telephone? And right now, today, what we are being asked, what the lowest common denominator is the telephone interpretation, and I do not find that sufficient. I do not find that to work well for our communities. It is an imperfect and unworkable solution today, and something that I hope that this chair and this committee accurately and adequately looks at.
Thank you. We, as I indicated, we can't take action today, but clearly this requires being addressed, and from my standpoint, the data doesn't lie. And if we see that there's an increase in those for whom English is not their first language or their preferred language, then there needs to be an increase in the number of people who can provide culturally competent medical interpretation services. And so I'm asking for the data so that we have a place to start for making informed decisions, and so that the committee has the ability to fully weigh that as it weighs all of the proposals that are before the committee, and would agree that in person clearly is more important, especially in the case of a life-threatening emergency. Thank you, sir. Thank you. Public comment.
Christina Romero on behalf of Planned Parenthood Affiliates of California in support.
Linda Way with Western Center on Law and Poverty in support. As noted, Medi-Cal plans and providers have an existing legal and contractual obligation to provide interpreter and other language services.
Thank you.
Beth Capel on behalf of California Pan-Ethnic Health Network and Health Access California in support. Medi-Cal managed care plans have had these requirements for 25 years. I hope, Mr. Chair, that you and the other members of this committee will press to see the extent to which they are actually providing the services that are needed. Given the testimony we've heard here today, there may be many requirements. We would wonder how well they are enforced.
Thank you.
Thank you, Mr. Chair, committee members. My name is Joanna Hester. I'm the national president of the Asian Pacific American Labor Alliance. 500,000 medical patients speak Asian Pacific American languages as their primary language, about 5% of the total medical population. Languages of lesser diffusion spoken by Asian Pacific American patients are often unaddressed by provider networks, adding to the barriers faced by our community. Many medical providers don't have the resources or ability to find interpreters in the API language. Even the speakers of top medical languages such as Vietnamese and Cantonese face tremendous access issues in healthcare. The API community is about 16% of the state's population and continues to be one of the fastest growing groups in California. I hope we can find support from this committee, strong support for this proposal. Thank you.
Thank you.
Thank you, Mr. Chair, members of the committee. My name is Christina Boss-Hamilton. I'm with UDW, AFSCME, Local 3930. I'm also here to reiterate the strong support for this proposal on behalf of our organization. Thank you.
Thank you.
Thank you, Mr. Chair. Don Shinsky on behalf of the California Healthcare Interpreting Association. Complicated subject once you crack the lid on it, but I would just want to concur at this point in the observation that Medi-Cal managed care certainly can and does contract to provide language services. It's always been very unclear to us whether those services actually get provided on the ground. Thank you.
Thank you. Any other public comment? Was there anything else that you wanted to add, ma'am? Did you have anything else that you wanted to add? Thank you. Anything else for you, Assembly Member Arambula? Senor Rodriguez, anything you wanted to add? ¿Quiere dice más?
Pues nomás que